This video is about a very short, sweet and simple message in life. When life gives you lemons, you make lemonade. So this is one situation where we have received some rigid IOLs from government supply, and we are supposed to operate patients and implant these IOLs. So what can be the best solution? This is the fundus photograph, and because the fundus is not very well visible, so this is the B scan, which shows nearly normal posterior segment, and this is the patient. So problem with rigid IOLs is that they need a larger incision, and so one has to resort to surgical procedures like manual small incision cataract surgery or extracapsular conventional surgery, where you place a large incision and you do ECC surgery. Here we have a situation where we are planning to implant a rigid large optic IOL, but at the same time we want to give the patient the best possible surgical outcome, and we have resorted to doing a phacoemulsification using a 2.8 mm incision. Now we will notice that I have given an incision which is very much close to the sclerocorneal junction, and the purpose is that we will extract the cataract using phacoemulsification, and at the end we will implant this large rigid IOL which will need a larger incision. And for achieving this, we will make the incision larger by increasing the size such that it becomes a small incision, cataract surgery incision, which is a frown shaped incision in the sclera. So incision has been made, capsular excision has been done, and conjunctival recession has been done so that there is no chemosis, because this incision is in the conjunctival area. So once this has been done, it is a straightforward cataract surgery. I use a horizontal chop technique, so we have created the first primary chop which is very well delivered, and we have further divided the nucleus into smaller segments and then consuming them so that half the nucleus is consumed. So this way we can do phacoemulsification, which is a closed chamber technique and essentially a superior technique considering the present trend, and at the same time also utilize the IOLs which are provided by the government free of cost for these patients, and can be utilized to provide good visual outcome and good surgical outcome without resorting to use of IOL which has to be purchased by these patients if they want phacoemulsification surgery. Now manual small incision cataract surgery is not a bad option. We're looking at all the outcomes and research publications which have demonstrated the visual outcomes are as good. But when we have a situation like this, it's like utilizing the best possible outcome for this patient with the available resources. So nucleus and cortex has been removed, and now enlarging the incision so that this large rigid optic IOL can be implanted. And as you can see, the incision has been converted in such a fashion that now it becomes a frown shaped incision which is self-sealing and also will not induce much astigmatism. So this is a 3-piece PMMA lens. As you can see, the optic and the haptic are different color. These are Prolene haptics. The IOL goes into the bag which has been created, opened by rexes. The IOL is implanted in place and it is well centered. Now once we have enlarged the incision, it is not very practical to use the irrigation aspiration cannula, because that has a faster aspiration rate, and at the same time this incision is going to leak fluid, so the chamber will collapse very easily. So we should switch to a manual aspiration technique, that is Simcoe cannula, which will have a better regulated aspiration process, and this can be used to remove the viscoelastic gel and any retained cortex. Here we see there is just a subincisional cortex left behind, which will be managed using the same Simcoe cannula. Once the surgery has been done, the chamber needs to be flushed of the viscoelastic and chamber has to be formed. This is the day 7 post-op picture, and we can appreciate the eye has recovered well and patient vision at this moment was 6.9 unaided with correction 6.6. Thank you.